But during general cardiology fellowship, you get exposed to, all factors. You cath, you do pacemakers, you see critically ill patients in the ICU, see patients in the office. So it's kind of a well-rounded experience to see the various facets of cardiology. You do imaging rotations with nuclear and echo and PET.
Dr. Toniya Singh, how are you doing, my friend?
I am great. Excited to be on here.
I'm excited to have you and talk to you again. First having you on Specialty Stories, now here on eShadowing with close to 300 of our close friends that want to learn about cardiology from you. So thank you for taking some time tonight to share the wealth of cardiology with the world. The favorite question that students love here on eShadowing is, what is bread and butter for you in cardiology?
Sure. So I'm a general cardiologist, so a jack of all trades and a master of none, as nowadays people speak. Cardiology can be a very broad and complicated specialty, but I enjoy the variety. So my day is spending time in the hospital, spending time with patients in the office, doing some procedures like angiograms, transesophageal echocardiograms, reading imaging studies like echocardiograms, nuclear images, CTs. Occasionally a PET scan. So it just depends on the day, but I have a fair amount of variety in my day. And I like the fact that I can read a lot of the stuff for my patients myself. So I already know the patient's history. I know what the patient's symptoms are. And so being able to connect across all these imaging modalities and, physiological and imaging testing is really helpful, I think, in kind of getting a whole picture for that patient. And then there are obviously many of my talented colleagues who do many other things that I don't. And then I can give them a good review when I send the patient to them saying, this is what the patient said, this is what we saw, this is what I think is going on, and this is how I want you to help. And I think the patient really likes having you kind of chaperone them through that because they feel like they have someone who knows them and has their back.
Do you think there's a difference? You mentioned being able to read stuff yourself. Do you think there is a better connection to the patient when you're able to sit down and look at imaging or look at a EKG or whatever it is and be able to read it with them versus maybe an internal medicine physician, family practice physician who's just going over what the radiologist is reporting? I know my wife, who's a neurologist, she can read brain scans herself. She can read the MRIs herself, obviously appreciates what the radiologist reads and definitely looks at that, but can also read it herself. Do you think there's a better connection to the patient because of that?
I think there is. I think the patient, I will pull up images in my office when the patient is in there and say, you heard me say this, but let's look at your angiogram. Here's that artery, and here's that blockage we talked about. Look, it's only 20%, or look, it was 90%, and we fixed it. So I think that visual, like a lot of people are visual learners, and to be able to connect their symptoms with something visual kind of helps them understand their disease process better and kind of builds a bond between you and the patient. I've been in practice for 18 years. I've seen many of my patients for many years. And so, you build trust, you build understanding, you build understanding about why you want them to do certain things, and you get more buy-in once you can share more of the disease process with them.
Yeah. So the 18 years you've been in practice, seeing patients for a long time, is cardiology, kind of painting with a broad stroke here, is cardiology generally a specialty where you have long-term patient interactions?
Absolutely. So cardiology is very much it's like internal medicine, I would say. So internal medicine focused on the heart. And now we know, everything else that we do, hypertension, diabetes, all those other risk factors, autoimmune diseases, all affect the heart. So you kind of have to be an internist along with being a cardiologist. So, you have to take a very good history. You have to spend time examining the patient. And people who say the role of the stethoscope is dead, I don't agree with them. We still get a lot of valuable information out of that. I use my stethoscope on every patient every day. And I've tried some fancy stethoscopes, but you still need something to listen to the patient with. But again, taking a great history, doing a great physical exam, interacting with the patient, asking questions, creating a differential diagnosis, all of those things that you do in internal medicine, you take into cardiology, and you are focused more on the heart, but you have to take into account all of the patient's problems because they all affect the heart. So it really is a great interaction with the patient. So in my job, the way I practice cardiology, I have a lot of patient-facing interactions. Even though I do procedures and read imaging, I also spend a lot of my day interacting with patients. But, there are other kinds of cardiology where you may not do as much of that patient interaction. But that's how I practice cardiology.
You mentioned kind of similar to internal medicine, those long patient interactions. to become a cardiologist, it's post internal medicine residency. So you have to know all of that medicine and take it into account when you're taking care of the heart. Talk about that training path to get to where you're at now.
So, internal medicine residencies on average 3 years, you get a chance to rotate in the ICU, the CCU, your flow rotations on telemetry. And then based on your interest, you get into cardiology fellowship, the first year of most cardiology fellowships. And most cardiology fellowships can be 3 years or 4 years, depending on which program you go to for general cardiology. So you could do 3 years of cardiology, 1 year of research. You could do 3 years of cardiology. You could do 1 year of EP. You could do 3 years of cardiology and an additional 1 year of interventional. You could do 3 years of cardiology, 1 year of interventional, and 1 year of structural. You could do 3 years of cardiology and a year of heart failure. So, if you want to subspecialize in cardiology, that's an extra year or 2 years, depending on the kind of subspecialty you're entering. But during general cardiology fellowship, you get exposed to, all factors. You cath, you do pacemakers, you see critically ill patients in the ICU, you see patients in the office. So it's kind of a well-rounded experience to see the various facets of cardiology. You do imaging rotations with nuclear and echo and PET and MRI. So you kind of learn a lot of different things, and then you can kind of find your place. I think that the kind of cardiology I practice is getting more and more rare as cardiology is becoming very complicated, and there are so many different procedural things that we can do. People are kind of becoming more focused on certain things. So people who actually see patients in the office tend to be non-invasive people. So, they tend not to do a lot of the invasive procedures. So things are changing, but you can still do what I do. And many people do that still.
Yeah. Talk about that non-invasive part for someone who knows, like in their core, they don't want to be a proceduralist and they don't want to do all of the invasive stuff. Can they get through a cardiology fellowship without doing that? Or do they have to at least have some level of competency to do that and to get through?
Yes. So there is a requirement to do some level of, I think you have to do a minimum of 300 angiograms. There's certain numbers of procedures. Just like when you're in internal medicine residency, to get through internal medicine residency, you need to be able to do a certain number of central lines and, thoracentesis and paracentesis. So you have a basic requirement of how many of those procedures you need to do. Like I remember we had to do 30 pacemakers when we were fellows. So I don't do pacemakers anymore, but I did do them in fellowship. And then depending on your level of interest, you may be all the way scrubbed in with your hands in the patient's chest, or you may be a little bit out and you may maybe go on suturing the skin every time. So it all depends on your, it still counts towards doing it. But if you're never going to do it later, you may be a little less enthused in the whole process. But you do have to learn that, because learning that is very important to take care of your patients later.
Awesome. Well, I know you have some slides to share and a couple cases to go. Why don't we jump into those, if you don't mind?
Yeah, absolutely.
I'll keep an eye out for questions. One
Sure.
question actually here that may be interesting is the correlation between cardiology and diabetes.
A huge correlation. So, diabetes is a big risk factor for coronary artery disease and also for congestive heart failure, diastolic dysfunction, high heart failure with preserved ejection fraction. And there is this whole new class of drugs that have come out in the last 5 years that have been shown to be very cardioprotective. So the SGLT1s, the GLP1s, so those are all SGLT2s. And all of those drugs are really very important in treating the metabolic milieu in which the heart lives. So we have found that diabetes is very impactful on the heart. So we do actually learn a lot about diabetes. And now a lot of us are actually prescribing those drugs, whereas in the past we didn't. And we are often now prescribing them in patients without diabetes, because there's now data that says that many of these drugs work for heart failure in patients who are not even diabetic. So there's certainly you need to know a lot of internal medicine and diabetes, like when you're treating patients in the office and the hospital.
Yeah.
Okay, so I'm going to try to pull up these slides. And I just have a few slides. I'm going to just start out with the different kind of subspecialties we have in cardiology, and then kind of go through a couple of cases. And please feel free to ask questions. I picked a few cases that are not things that we normally talk about in cardiology, and there's something newer. So that's, you all know about coronary artery disease. That's not necessarily something I'm going to be talking about today. So just different forms of heart disease. So again, let's see, sharing my screen. So, like I said, the stethoscope is, let me get the screen mode. Okay, so the stethoscope still is important, in my opinion. But you don't necessarily need to spend the $500 on getting the electronic stethoscope, because in my opinion, you don't hear that much better with that as compared to, I don't know, for some reason, I don't want to go to screen mode. So we'll just go without. Yeah, it's fine. We're all friends here, right? Maybe.
We had a cardiologist in medical school tell us the most important part of a stethoscope is what's between the earpieces.
That is so true, because if you don't recognize what you're dealing with, then you can't recognize how to manage this issue. Yeah, so it certainly is a problem. Okay, so our next slide. Oh, there we go. Finally, we can do this. I just want to bring up the fact that there are many cardiology subspecialties. The fact that, you could be an interventional cardiologist, you could be a structural cardiologist, you could be electrophysiologist, you could do heart failure, you can do heart disease in women, you can do... I think I lost you there for a minute.
We're here.
Oh, I seem to have lost my screen.
That's all right.
1 second. Sorry about that.
No problem.
I'm just going to log back in because I can't see anything. I have a new monitor. That's the problem.
Multiple monitors always messes things up.
Excuse me for 1 second and I will be back.
No worries. I'll do a little dance.
Okay, sounds good. You entertain everyone while I get back. Okay, be back in a sec. Oh, now I'm back. Okay.
Hey,
I can turn my screen off. Anyway, I'm going to try this one more time, but I'll try not to get too fancy with the PowerPoint. Anyway, so I was just pulling up our different subspecialties. So we have the ones that I was reading out before, and then the newer subspecialties like are heart disease in women, which women present differently with heart disease than men. There's more imaging. Earlier we used to just do echo and nuclear. Now we do CT and MR and PET. Pediatric cardiology is a whole big different subspecialty. So if you're a pediatrician and you're dealing with children with congenital heart disease, and those children grow up, and so then you can become an adult congenital heart disease specialist as well. Lipids is a big factor. Cardio-obstetrics is a relatively new subspecialty where we really, a pregnancy is a woman's first stress test, and there's many things that we learn about during a pregnancy that actually predict patients' long-term outcomes, which we never used to pay attention to. Yeah. But that is a part of the history that I take very seriously now. And then prevention, of course. Prevention is very important. So
why don't we do prevention more in this country?
Prevention is so key, but again, and we have more preventive cardiologists now because there are many things we know that we can talk about prevention that we weren't able to do before. So I'm going to attempt to share my screen one more time, and let's see. Okay, I'm just going to leave it here, and then so my first picture I put on here was this is a picture of a coronary angiogram, as you can see. But the history on this patient was this is a 28-year-old woman who is very fit, runs ultra marathons, and is working out on her Peloton and has chest discomfort and comes to the emergency room. She's having crushing chest pain. She's short of breath. She's not sure what happened because she does this all the time. So she's never had a problem before. And she's 28. And so
Peloton and CrossFit are the two most dangerous things of activities that people do these days.
And so this is actually one of our patients. So this girl is 28. She shows up in the emergency room with chest pain. And, the first thing everybody says is she's 28. She's having chest pain. She's probably just freaking out. She looks really fit. And so we do an EKG on her. EKG is fairly unremarkable, which was kind of interesting with this angiogram. But I'll explain the angiogram here in a minute. So she continues to have chest pain. So we obviously draw a troponin, thank God, because, we draw a troponin on everybody who stubs their toe in the emergency room, but this lady had one, so that was good. And her troponin was actually pretty high. And so the ER doc actually comes and calls me. I was on call that day and said, we have this young woman here and she's having this chest pain and she looks really sick, but her troponin is high, but her EKG looks okay. So I came down and I talked to her, and so we ended up taking her to the lab that afternoon. And so we did an angiogram on her, and what we are seeing here is the artery up at the top that looks normal is actually her LAD, but the one that's in the back that looks all kind of hazy and narrowed out, where you see all those arrows, that is a spontaneous coronary artery dissection. So basically the intima of the arteries tears. And one of the things that, people say, what do we do about this, right? So the standard way we've treated coronary artery disease all these years is put a wire down, put a stent in, open this artery. But in these people, doing that actually makes the dissections worse. So it's the hardest thing for the interventional cardiologist to do nothing when they see this angiogram. So the way you support this patient is, this patient, fortunately, she had a normal LV gram and we did that. And her pain, and we gave her nitro, we gave her morphine. and heparin, and her pain started resolving by the time she got to the lab. And so we didn't do anything. And I don't have a follow-up angiogram, but her follow-up angiogram, her artery looked normal. So what we used to do in the past, about 5% of acute coronary syndromes can present as spontaneous coronary artery dissection. And classically, they tend to be healthy people who work out all the time and then tend to have very classic chest pain. Sometimes they have ST elevations on their EKG, but it's really important to recognize this because the treatment of this is completely different than how you would treat an acute MI. Now, sometimes if the vessel is closing, the patient's crashing, we will try to open it. But if the patient looks hemodynamically stable, you kind of have to step away from the table, which is really the opposite of what we've been doing for years. And so that's something that's new, So every lesion doesn't need a wire down it, and every lesion doesn't need a stent, and the heart can canalize and treat this. So we treat this patient with beta blockers. And another thing, these patients don't need statins because this is not being caused by an atherosclerotic plaque. So there's actually some data that statins are not helpful. So the reason I brought this case was it is the opposite of how we treat coronary artery disease in general. So I just wanted our students to see something that, makes them think that, all etiology of all blocked arteries is not plaque. Sometimes it's a dissection.
So what happens to the dissection? So just for people to kind of picture a wall, right? For those who maybe don't know what a dissection is, you have the wall, and then part of the wall basically tears off and is blocking the normal lumen. Does it just scar back down over time?
Yes, it can. So if the key is if you give people, once you see that that's the thing, sometimes the artery will close off completely. Mm-hmm. Sometimes it will build collaterals, and sometimes it will recanalize on its own. But the more you instrument the artery with a wire, the more you damage the dissection plane. And that's why they recommend not doing that. Now, we also have a instrument called a IVUS, or an intracoronary. It's basically an ultrasound that goes inside the coronary artery. And that allows you to actually look. So you can go right by the edge of the artery where the dissection starts, and you can look and see what's inside. It tells you there's no plaque there. There is a flap. And that allows you to kind of, realize. So you treat people with medicine. Sometimes tacking back the flap is not easy. Because remember, like you just said, there's a flap that's torn off. Blood is going down that plane. It's pushing the flap down. The more things you put in it or try to instrument it, the more damage you can cause. And the patient crashes. I mean, the body has better healing mechanisms in the way we treat this. So you can't staple it back on. You can't, glue it back on. You just have to kind of let it rest. And eventually the body will recanalize it with anticoagulations because you don't want it to clot off. So that's why you put these people on heparin. You give them nitrates to get the vessel lumen as big as possible. You give them beta blockers to reduce the stress on the heart. But this is a case where, giving a person a statin is not going to make any difference. Putting a stent in is not going to make a difference.
Because that wasn't the problem to begin with.
That wasn't the problem to begin with. So I just wanted to bring this as a thing that we see. And now that we recognize it, we see it way more. Because earlier, like when I was in fellowship, I'm like, nobody had spontaneous coronary artery dissections unless the fellow dissected the coronary by injecting dye inside there. And it was the fellow's fault, right?
Yeah.
But now we realize that maybe it wasn't the fellow's fault. Maybe there was a dissection there with our first picture. So that is just, and it happens, about 80% of this is seen among women and young women, young healthy women. And it is also then associated with another disease. And that's why I brought that up, because a lot of people have heard of that. And that is called fibromuscular dysplasia. So fibromuscular dysplasia patients can have spontaneous coronary artery dissections. And with fibromuscular dysplasia, you see that in young women who are hypertensive, but it can also impact, let me see here. Okay. So it can also affect your renal arteries, which most medical students will have heard of fibromuscular dysplasia and, hypertension amongst the young patient. But in those patients, basically what is happening is the endothelium, mesothelium connections are not very good. So they get these little aneurysms and abnormalities. But the same thing can happen in the coronaries. And then the same thing can happen in your carotid arteries and in your femoral artery. So it can be a something. So if you ever see a patient with a spontaneous coronary artery dissection, make sure you scan their carotids and you scan their kidneys, because all three of those things can exist together.
Do we have any physiology on why it's more common in women?
there's really no real understanding it. I mean, that's part of the studying. This has really been something that's been studied a lot more in 10 years ago. When they say a lot of women don't get into trials, this study was actually done through the Mayo Clinic through a bunch of women's magazines, asking women to send in, women who had chest pain and had weird young women with chest pain, and they were able to gather a lot of this information. You also see it sometimes in people with other, vasculitides like, Ehlers-Danlos. You can see it. I have a patient who has a corneal dystrophy, and she's had spontaneous coronary dissection. She's had 3 corneal transplants, and she's had 2 spontaneous coronary dissections. So there's something wrong with the sticking part of her endothelium. So there are other, now that we recognize it, we are making all of these connections, but we didn't in the past. So that's why I just wanted to bring this as a kind of a different sort of case of something you might see as medical students and as you're out and about.
Yeah.
The other thing I wanted to talk about was, advances in cardiology. So, we've had valvular heart disease around forever, and we've been treating people with open heart surgery forever. And now we've gotten to this whole place where we can treat a lot of problems without cracking people's chests open. So I just brought a video of a percutaneous valve placement. So this is a valve placement in the aortic valve, and it's basically a diagram that shows you we actually start out in the leg. We put a catheter up from the leg, we go across the aortic valve, let me play it, and then we'll talk about it as it plays. I'm sorry, today okay. I'm not being very technically savvy.
That's okay.
Okay, well, I don't know if you get a chance, watch it on YouTube. It's called a TAVR. Basically what happens is you put a valve in from the leg, and you go across the aortic valve with a wire, and then you can actually implant a valve from the leg. So you don't really actually even have to go open the patient's chest. And this is really great for people who've had previous bypass surgery, who are frail, who are old. They're in the hospital for a day or two. They go home. It's amazing what an advance that is. So, and you can also do that for the mitral valve now, which is a little bit more complicated than the aortic valve because you have to go, across from the right side to the left side, but it's still an amazing procedure. If you get a chance to watch it, do that. That would be, very interesting to watch. And then the last thing I want to talk about is cardio-obstetrics. And the reason I bring that up is, this is something that is very much newer than what we talked about. And there's so many factors that we don't even think about when we are taking a history. And so I think since I'm talking to medical students, I think it's really important that when you are going through all your rotations and you're getting history, just incorporating this into your thought process is very important. So there are, sex influences and their gender influences, and the, premature menopause, that's menopause before 40, gestational diabetes, hypertensive disorders of pregnancy, which is eclampsia, preeclampsia, preterm delivery, which is delivery before 37 weeks, polycystic ovary syndrome, and any kind of systemic inflammatory and autoimmune disorders, which, occur more in women. All of those really increase a woman's risk of having cardiovascular events later in life. And they also may increase the child's risk who was born prematurely of having more cardiovascular risk later. And then, we already know all the well-established factors, so I'm not going over them. But then there are also these under-recognized risk factors of psychosocial risk factors and abuse and intimate partner violence and socioeconomic deprivation and poor health literacy and environmental risk factors of living in environments that are, not healthy or very stressful. That also increase cardiac risk. So I think those are also some kind of unusual risk factors that we always don't take into account when we speak to our patients, because we all know the traditional risk factors. So I just wanted to bring that up. And that's all I have in terms of discussion. But I'm happy to discuss any of this or more, or any questions anybody has. But I do have one more slide that I'd like to talk about before I get done. And that is, we did a paper about why only 14% of cardiologists are women. And we are working really hard on changing that perception. I can tell you as a woman cardiologist, it is a fantastic job, and I wouldn't do anything else given a choice. So, and the barriers people talked about were like, cardiology does not have stable hours. It's not necessarily family friendly. It is not female friendly. You don't see as many women as role model cardiologists because, 86% of cardiologists are still men. There's financial benefits, yes, and sometimes subspecialties that pay very well tend to be very much more competitive, and sometimes women apply to them less. There's professional challenges like in any specialty. The advantages are it's really a patient-focused specialty, and you can have a fantastic career. So I would like to say that, just going back to the discussion about when I talked to you about the different kinds of cardiology, remember what kind of cardiology you pick kind of defines your hours. So if you're an interventionist or you're a structural physician or you're an electrophysiologist or a heart failure doc where, you are waiting for transplants, then your hours will be different. You will be more procedural. You will spend more time in an acute care hospital. You will maybe have more call at night. But if you're, running a heart disease for women center, you're mainly an imager, or you are taking care of lipids, or even cardio-obstetrics and prevention, those are all more office-based specialties. So you will not be spending as much time in the hospital, and you will not be taking as much night call. Of course, it's a personal choice, and you certainly want to factor in what excites you in cardiology and what you like doing, and then pick your specialty based on that. But there are all kinds of cardiology. So, cardiology is not just one thing. And that's why I just wanted to put this slide up to kind of, bring that to everybody's notice.
Yeah. Why did you choose cardiology?
So I chose cardiology because my dad had bypass at 15, and I was really interested in his whole physiology and everything else. And he was 47 when he had his bypass. So he was young, and he didn't have a lot of the traditional risk factors, except he was South Asian. And being South Asian is a major risk factor, even in the absence of hypertension and diabetes, because our lipid profiles are not very good, and we all have some degree of insulin resistance, which apparently is very atherogenic. Yeah. So there was a study about that, studying the details. But he's 80 now, and he's doing fine. So, their cardiology is fantastic. You get to keep people around for a long time and give them good lives. And so, it's really, I really enjoy about cardiology is the acute part of taking people when they're sick, getting them through their bypass surgeries or their stents or their acute MIs, their valvular heart disease, and then seeing them for years after when they bring me their, pictures of their grandkids or, they're living normal lives and tell me about the last vacation they went on, which is what you really want. You want to get people well so they can go and live their lives. You really don't want people to be sick all the time. So cardiology is a subspecialty that provides so many tools to improve the quality of life of our patients. Yeah. And for us to kind of see that is so gratifying. So that's what I love about it.
That's awesome. All right, I'm gonna start bringing some people on to ask some questions. So if you want to come ask a question, go ahead and raise your hand, and I'll bring you on. If you want to stop sharing your screen,
yes, I will unshare.
What do we know? A couple of people have asked this question. What do we know, if anything, long-term risk with COVID?
So I'm seeing a fair number of patients in the last few months who are very fatigued. They have inappropriate sinus tachycardia. They have orthostatic hypotension. I've had a couple of people with a cardiomyopathy, but it's not very many. I've had lots of patients with pulmonary emboli that are now dealing with just getting better from there. Some of them have developed some pulmonary hypertension. I've seen a few people with venous and arterial thrombi, but fortunately, nobody has lost a leg from there yet, so that's good. But just the recovery from anytime somebody has any of those things happen to them, their recovery is very prolonged.
Yeah,
that's so those are the things that I'm seeing.
Yeah,
just a lot of fatigue, a lot of like the post-mono kind of illness is chronic fatigue.
Yeah, interesting. Okay, Amy, you have a question?
Yeah, can you hear me? Okay, I have more of a general question of how you prepare yourself or what things we should get in the habit of now for the constant learning of medical school and residency, and as a attending, how do you constantly keep yourself up to date on the newest technologies, and just what are your learning techniques that you've discovered?
Sure.
I love that question. I want to just interject before you answer. I love that question because I'm pretty sure we have data that shows that most physicians aren't good at staying up to date, that they practice the way that they are trained and they don't do a good job of staying up to date. So hopefully you're better at it and can help these future physicians.
I think in cardiology, you have to, because if you use, because cardiology is constantly changing. Like, when I became an attending, they used to give diltiazem to people with acute MIs. Now nobody gives diltiazem to people with acute MIs. So, we never used any of these diabetic drugs. They didn't even exist. All the heart failure drugs we used didn't exist. When we used to start carvedilol in patients, we used to start them on half of 3.125 and put them in a room and monitor them for 2 hours. Now I start people on 6.25 and send them home and say, come back in next month. So So there is constant change. The way I keep up is I listen to a couple of podcasts that I really like about cardiology, which I listen to in my car often. There's an Excel, the Journal of American College of Cardiology has an Excel podcast that you can listen to. There's a bunch of fellows who run a podcast called Cardio Nerds, which is really good. So they do that. I listen to that because they get all this, basically 2 or 3 people who are specializing in one particular, disease process, and then you can hear about that and sort of keep up with whatever is latest on there. I'm on Twitter and I follow the hashtag cardio Twitter. And if you're interested in cardiology, it's a good hashtag to follow. There are some wonderful people who put up every useful paper and give you a quick little summary of it. And so if you feel like you want to read the whole thing, you can, but if at least you feel like you're updated. And then when my patients walk into the office, I've heard about it already. So they don't come to me with things. I'm like, oh, where did you hear that? I'm always like, and I only spend maybe about 20 minutes a day on Twitter. So I don't spend a lot of time on Twitter, but I'm really focused on like maybe about 100 of my friends who are in different subspecialties of cardiology who post things that are important in their subspecialties. So as a generalist, it allows me to kind of keep updated. I don't read my JACC journals regularly, but the JACC journals are very smart. They do a podcast of a quick overview of what was in the journal. I guess they know all cardiologists have short attention spans. So we listen to that. I listen to that from time to time. So yeah, those are the things I do. And I go to conferences. I love going to conferences. I learn, I meet people. In the pre-pandemic world, the before times, that was another way for me to learn.
Awesome. Thank you so much.
Thank you. Podcast for the win. Gotta love it. Daniel.
Hello, can you hear me? Yeah, I just have one quick question. So we've seen in the headlines of, COVID vaccines increasing the risk of myocarditis. Have you seen a lot of cases where the myocarditis was linked to the COVID vaccine?
Actually, I have not, but that may be because I'm an adult cardiologist. So my pediatric colleagues would have seen, they say the 18 to 20 age group, those kids are kind of still in the, more still seeing their pediatrician than coming into my office. I don't see anybody under 18. I personally have not seen a single case of myocarditis. When the COVID vaccine was given out in the spring to the 12 to 18-year-olds, that is a common time for myocarditis to be higher anyway because of Coxsackie virus and a bunch of different spring viruses. So there is a signal that it may be a little bit higher, but it's not a big change. And of course, the risk of developing myocarditis if you actually develop a clot from a coronary clot or a pulmonary clot from your COVID, that tends to lead to a lot more problems. So I have a full disclosure 20-year-old, and I told him to get the Pfizer shot as soon as he was eligible. So I was not that concerned about myocarditis risk. And from what I heard, I think that the risk is very minimal.
Yeah.
Okay, thank you.
And they're recovering. My father-in-law's a medical mystery. He's 75-ish and got myocarditis post vaccine. But he's if anything were to happen, he's the 0.1% that it'll happen to. So.
I mean, there's always something that can happen to anyone. Like you could get in a car wreck on the way to the vaccine or on the way back. Or,
Exactly.
My son was like, "Are you sure?" And I'm like, "Yes, go get the vaccine."
Go now. Yes. Sawith.
Okay.
Oh, you muted yourself. Hello. Sawith, come back. There you are. Nope. One click. Be patient. One more time, Sawith. Come on. I know you can do it. Going once. Going twice. Akujijio. How do you say that? That's awesome. How do you say that? All right. Sorry, Sawith. Akajujio. Jugo. Unmute. You are muted. Apparently nobody knows how to unmute.
They're having the same technical difficulties I was having. I swear, I put the new screen up in my room today. I was very excited, but I think I should just stick with my old system.
Yeah. Oh, Jenny? Is that how you say that? She came on. Oh, Jenny. She came on. She's like, I'm going to show them that I know how to use this. Go ahead. What's your question?
My question is how you've seen cardiology affected with a plant-based diet, and have you ever had somebody switch from a carnivorous diet to an omnivoric or an herbivore diet, and have you seen any changes in their cardiology after that transition?
Absolutely. So I would say that there is lots and lots of data that going from a carnivorous or omnivorous diet to a plant-based diet is really heart healthy. But obviously, you have to make good choices when you go to a plant-based diet because French fries are also on the plant. So
darn it.
It's really important when my patients say, well, I'm going to give up eating meat. I'm like, wonderful. What are you going to eat? So, it's really important to discuss the quality of the diet. And I have a couple of women I know who are really, very much in their prevention clinics talking about plant-based diets, but a lot of them will give out actual recipes to their patients. I talk to them about this book called Forks Over Knives, which is a good suggestion about how you can make that shift. Because if you just tell somebody to go home and stop eating meat, really their choices become, and if they're not a vegetable eater and they don't know how to cook, sometimes they make poor choices. And even like salad dressing, for instance, blue cheese dressing is, I guess, sort of on a plant-based diet, but but really not. So I would just say yes. There's lots of data that it's very helpful, and I totally encourage it. If my patients are willing to try it, their cholesterol usually drops 50, 60 points. Sometimes they don't need to. It really works well in people who haven't had coronary artery disease yet. So I do a lot of calcium scores on my young patients with family histories of heart disease. And if their calcium score is 0 and their LDL is, 160, for instance, or 150, and they're like a 35, maybe I wouldn't do a 35, but maybe a 40-year-old woman. So a 40-year-old woman who's like getting into the perimenopausal time, or is a little overweight, her A1C is like 5.7 and her LDL is 140. That's a perfect patient to make a dietary lifestyle change, because their calcium score is 0, their risk is low. By doing all of these changes, they can stay off more drugs, and they're all kind of mentally open to that at that point. So I'm a big fan of it. So I think it works great. And you see drop in blood pressure, you see drop in lipids. Absolutely.
Thank you. Am I able to ask one more question?
Yeah,
sure.
With total artificial heart and LVAD patients, what treatment is there long-term post those devices? And then what typically causes a patient to have those devices implanted?
So LVADs are basically bridge therapy. So you have a patient who has congestive heart failure of any etiology. That is somebody who, so there could be two choices in that patient's life. One is that they're young enough and don't have a lot of other comorbidities, and they can get on a heart transplant list, but they've gotten sick before they get the transplant. So the LVAD basically kind of helps bridge them till they can get a heart, because hearts are hard to come by. The other second choice of the patient is somebody who's old. So somebody's over 75 and they have cardiac amyloidosis or any kind of or ischemic heart disease, or now are at the stage where their ejection fraction is dropped, they're on optimal medical therapy, and they're now starting to crash. That's the person you can put an LVAD in, knowing that that's just a bridge to death. So you can help them live a somewhat decent quality of life for the next 2 years, 3 years, depending on how well they take care of themselves and how well the LVAD works. But that's just a bridge to, till it stops working. So those are the two pathways. And usually, you send a patient like that to a center for advanced heart failure, where they're, taken care of by the advanced heart failure guys who can make that assessment and then there are some patients who are not LVAD candidates, because once you develop renal failure, you can't get an LVAD, because people's mortality is extremely high with renal failure and heart failure combination. So then they don't remain candidates for LVADs. So there's a very, very narrow window of time where you need to get this patient to advanced heart failure specialists so that they can get benefit from that.
Thank you.
Okay.
Great. Thank you so much. All right, Piper.
Hi, can you hear me?
Yep.
Okay. I saw someone else ask it earlier. Sorry, I'm in my pajamas. But I saw someone else ask it earlier, and I was just also really curious about it. Is it possible that you could become a different subspecialty once you have already picked a subspecialty, or could you be more than one subspecialty if you so chose?
Yeah, absolutely. It depends on how much time you want to spend training. That's usually one big part of this whole equation. But I know people who are cardiologists and critical care doctors. So they've done a cardiology fellowship and then maybe gone to a program that does critical care, and maybe done a 1-year critical care program. So you're talking about two different things, right? You're not talking about subspecialties within cardiology, because once you're
subspecialties within cardiology, because I saw you had one that was like cardio obstetrics, and then another was like imaging.
Cardio obstetrics is, you don't do obstetrics. No, you are not doing obstetrics. So you're a cardiologist who is dealing with the heart of pregnant women.
Yes.
So you are actually not performing the C-section.
Yeah.
And cardio obstetrics is now not a formal subspecialty, but there are many centers that have they work very closely with their OBGYNs. So, they're in the same office essentially. And so, women with adult congenital heart disease and all those, risk factors that I talked to you about, they get to see a cardiologist early in their pregnancy, and they get to follow with a cardiologist, and then they get to follow with a cardiologist later once they have the child. Because, for many women, their gynecologist or their obstetrician is their primary care physician. And so we've actually worked with the American College of OBGYN to create criteria to remind them that many women need to be followed after they have their delivery. And if you see a pressure of 140 every time this woman comes to your office, it's a problem, So there's a lot of education there, but you don't really need to spend extra time training. You probably, if you go to a program that has a lot of cardio OB, you learn from there. But if you want to be an electrophysiologist, you have to spend an extra year. So you become, like, I don't do EP, but after general cardiology, you spend a year, then you can do, electrophysiology, ablations, you can put in devices, things like that. Or if you do structural heart disease, you can put in aortic valves and mitral valves. Or if you do interventional, you can put in stents or fix people's legs. So you can do subspecialties after doing cardiology.
Okay. And also, if we have time, I have one more quick question. So I actually have POTS, if you know what that is. And I was just wondering if you see that commonly in like young women, because my cardiologist told me that she sees it commonly in young women. And I was wondering how you personally treat that. I'm just curious about it because I don't know many people with it.
Yeah. So I would say it's all my POTS patients are women. And I do see POTS often, and that's postural orthostatic tachycardia syndrome. People who are not familiar with it. It's a very hard disease to treat. The only good thing about POTS is most people get better as they get older. It's probably the only thing that gets better as you get older. But I tell all my patients that there's hope in the future, because as your autonomic nervous system stops getting so sensitive, actually your symptoms improve.
Okay.
It's better in pregnancy, of all things.
Really, I did not know that.
Patients, because their volume doubles. Your volume doubles during pregnancy, and when your volume is high, people feel better. So
I did not know that. That's so interesting.
It is it's a very difficult disease, and I think it's also a combination of many things. So it's very hard to treat. Every patient has either more postural orthostasis or more tachycardia. Not everybody has the same constellation of symptoms.
Yeah.
So I certainly think that, but yeah, it is a very women-centered disease, and all my POTS patients are women, and I treat them with a variety of things like, some beta blockers, some midodrine, some Florinef, some IV fluids, compression stockings, hydration, beta blockers, SSRIs. Every patient requires something different. I wish we had a better standing, a handle on that, but it is a challenging process.
Yeah, mine's mostly SOL and SSRIs and compression socks.
But like I said, it'll get better with time. So that's one encouraging.
Yes.
So,
yeah.
I don't see many old patients with POTS.
Go have some French fries with salt on it.
Yes.
be a vegan. Tiffany, hello. You're muted.
I turned the video on, but not the audio, so you could just read my lips. So I had a question about the procedures that you do. As a cardiologist, what procedures do you do, and how is that different from like a vascular surgeon?
Great question. So as a cardiologist, I do, like the vascular surgeon, I do angiograms of the legs and the arms. So they do those, but I also do angiograms of the heart, which the vascular surgeons don't do. And the way you approach all of these angiograms is pretty similar. You either enter in through the femoral artery or you enter in from the radial artery. I do 80% of my cardiac angiograms through the radial artery. And I find that much more comfortable for the patient. The recovery for the patient is much easier. They just leave with a little wristband for 2 hours and then they take it off, and there's no leg bleeds and groin hematomas and all of those issues. And there's data that it's much safer in terms of bleeding risk. Women tend to have smaller arteries. Women are just special. And they tend to spasm more, so we tend to use vasodilators when we do that. So I don't do that, but my partners do put in stents in the aorta. They put in stents in the heart, just like the vascular surgeons. They put in stents in the legs, like the vascular surgeons. But we don't necessarily do any open procedures. So a vascular surgeon might do like a bypass on the leg. We won't. So they'd still do open surgery. All our work tends to be percutaneous and not a lot of open.
Okay. A lot of the cardiologists try to move more so towards I guess all surgeries try to move more so towards less invasive procedures. So it seems like in time, it's going to be more so the cardiologists doing a lot of the procedures. And also you get the opportunity to stay with your patients for a longer course of their treatment than the vascular surgeon would normally.
So we follow our patients forever till they check out and move on. So I think that we have a lot more impact, and we pay a lot more attention to the medical therapy, not just the procedure itself. The procedure is just one part of the whole. Great.
Oh, and then what about research? What opportunities are there for cardiologists to be involved in research?
So there's multiple opportunities. It's a great question, Tiffany. So depends on your institution. So if you're in an academic institution, you sign up with NIH trials. You can become a researcher, like a investigator yourself. I'm in private practice, and we still are involved in a lot of clinical research. So we did a lot of the research studies for using rivaroxaban, low dose in patients with coronary artery disease and PAD. We actually had the most patients in the world enrolled from our practice. It's really an interesting statistic. But we do a lot of diabetes drug research. We do research for HFpEF. So we enroll our patients in those trials and kind of follow them. So yeah, we are involved in clinical research. So it just depends on your interest. Of course, if you want to be leading a trial or you want to be writing papers about leading trials, then you are better off in an academic. So we don't design trials. We just enroll our patients in trials and then see.
I'm sorry, last question. Is it possible while being in private practice to still run the research yourself as opposed to enrolling patients in it, to have more so like guiding the research?
So usually the pharmaceutical companies want to go to academic institutions with known names, with track record, with papers to do that. And I think that is appropriate. I think those people are better trained, and that's a big part of their.
Okay. Thank you. Thank you so much.
Thanks, Tiffany. All right. Sawith, fingers crossed. Maybe.
Can you hear me?
Yes.
Oh, wow. Amazing. Okay. I think it was something wrong with my headphones. Okay. So the question I had for you, Dr. Singh, was that you mentioned the South Asian statistic, right? Specifically among men, there's like a higher risk for cardiovascular disease. And my dad had bypass done when I was 14. So I got to experience it firsthand. So do you think it's more like genetic or environmental factors about like how you eat, or like, again, it comes up to the debate that nature versus nurture. What do you think has the heavier weight in terms of that risk you mentioned?
Right. So they're actually doing a trial called the Masala trial. Now, don't ask me to tell you what all that acronym stands for, but they're looking at people of South Asian descent. And so far, they've realized that there is some metabolic abnormalities that predispose us to premature atherosclerosis, also having coronary arteries. So basically, the way I look at it is, I need to screen all my South Asian patients more aggressively, faster, earlier, at a younger age, especially if they have a family history. They need to be screened for diabetes younger. So a South Asian person's BMI should be less than 23, because if their BMI is 25, they're overweight and their metabolic profile will already be off. So, the parameters that we use to look at different ethnicities and different genders, I think we just need to start, refining them better, because risk is different for different people. So, I don't know the answer of what it is, but keep track of the Masala study, and they are working on finding the answer for that. And hopefully, for all of us, me included, I'm getting to that age of premature group, and be more vigilant. Know your A1C. I mean, every South Asian person should know their A1C, and they should work on making it under 5.6, and watching your diet and exercising and looking out for abdominal obesity. All of those things, increase your risk. Those we do know. So working on it early is important.
Okay, amazing. Thank you.
Thanks, Abba. And last but not least, Anish.
All right, so my question is, during surgery, how important is the medicine that anesthesiologist gives to the heart patient? Because during resting, doesn't the blood pressure change, and that affects the heart speed and function?
Great question. It's why I get asked to give surgical clearance to all my patients before they go have any surgery. So, depending on the kind of surgery, the anesthesia is different. So if you're having something minor, we use propofol, which, by the way, can slow your heart rate down and reduce LV contractility. So it's not a great drug to give people with bad hearts. But, you kind of have to know your patient's heart muscle function. You need to know their anatomy. You need to know if they have a history of congestive heart failure, severe aortic stenosis, if they recently had a myocardial infarction, if they have any arrhythmias like atrial fibrillation, if they have horrible sleep apnea. All of those factors are something that the anesthesiologist needs to be aware of. So when I see a patient pre-op for surgery, I look at all of those things and make some recommendations saying, patients at high risk for an arrhythmia, or patients high risk because they have horrible sleep apnea, make sure we have a good airway, make sure you're monitoring their oxygenation status well. And then the anesthesiologists are very smart people who know what kind of right drug to use for that. But that's part of our job as a cardiologist, is to basically go through a matrix where saying, how serious is the surgery? what is the patient's baseline status, how do you match the two, and what is your... Occasionally, I would say the patient can have surgery because the surgery is not important and the patient will die if somebody puts them under. So, they just have to live with whatever leg pain or whatever they're having. They can have some cosmetic or orthopedic procedure that's not going to change the quality of their life or longevity.
All right, thank you.
All right, it's a good question, Anish. And with that, Dr. Toniya Singh, thank you so much for coming on again. First time with Specialty Stories podcast. If all of you are here and you don't listen to the Specialty Stories podcast, what are you waiting for? Even Dr. Singh listens to podcasts you should be listening to. Thank you so much for taking some time to join us tonight and share some wisdom about cardiology with everyone.
It was my pleasure. And, cardiology is a fantastic specialty. So keep that in mind as you go through your rotation.
Yes. Awesome. Everyone have a wonderful night. We'll see you next time on ep46. Bye.
Good night.